Is this because of nitropocide? And nitropocide has cyanide toxicity. Okay, this patient, this patient with a hypertensive emergency was treated. This patient with hypertensive emergency was treated with sodium nitroprusside, a potential arterial and venous vasodilator after 36 hours. After 36 hours, he developed acute neurologic symptoms, confusion, hyperreflexia, and a metabolic acidosis, a presentation most concerning for cyanide toxicity. Sodium nitroprusside contains 5 cyanide groups, and sodium nitroprusside contains 5 cyanide groups and undergoes rapid conversion to cyanide. Cyanide is eventually converted to thiocyanate, which is eliminated by the kidneys. However, especially in patients with renal impairment, prolonged nitroprusside infusion more than 24 hours can lead to cyanide toxicity. Cyanide inhibits mitochondrial oxidative phosphorylation. These forces cells to switch anaerobic metabolism, leads to cellular hypoxia, lactic acid formation, and metabolic acidosis with elevated anion gap. Neurologic symptoms, headache, confusion are common due to cerebral cellular hypoxia. Hyperreflexia is caused by thiocyanate accumulation, and other possible manifestations include cardiovascular and respiratory instability, GI symptoms, and reddish skin. In addition to in addition to medication use, other etiologies of cyanide toxicity include combustion of carbon and nitrogen containing compounds, wool, silk, industrial exposure, and metal extraction mining. Okay, yes. In patients with chronic hypertension, cerebral vessels may not autoregulate, which can lead to global hypoperfusion and cerebral ischemia if blood pressure is lowered dramatically. However, this patient's blood pressure was appropriately decreased by approximately 25% over 36 hours, making the diagnosis unlikely. In addition, elevated anion gap metabolic acidosis would not be found in this case. E. Uremic encephalopathy. Uremic encephalopathy can present with altered mentation. However, it usually occurs in patients with acute advanced renal failure. These patients' mild rise in creatinine 2 to 2.5 milligram per deciliter is unlikely to cause uremic encephalopathy. Okay. Yes, the decontamination, supportive 100% oxygen, IV fluid vasopressin, and empiric is vitamin B12 hydroxycobalamin with or without sodium thiosulfate. Can you hear me?
Okay, now, yeah.
Okay, sorry. I was reading the explanation. Okay.
Oh, you want to read the explain.
Okay, this patient has secondary nocturnal aneurysis defined as new onset nighttime waiting. This patient has a secondary nocturnal aneurysis, a new onset nighttime waiting after achieving urinary continence for more than 6 months. In contrast to primary nocturnal aneurysis, which is often developmental and resolves with time. Secondary aneurysis is more likely due to medical condition, UTI, diabetes mellitus, psychological stressor, patient's divorce. As a careful history and physical examination, the first step in evaluation of all patient the first step in evaluation of all patients with nocturnal aneurysms, both primary and secondary, is urinalysis. Urinalysis is a simple test that can assess for a medical cause of aneurysm. Treatment of the underlying condition typically leads to a resolution of aneurysm. For example, UTI can present in children. UTI can present in children with new onset incontinence, even without even without typical symptoms of dysuria or abdominal pain, and leukocytosis and or on nitrates on urinalysis are supportive for the diagnosis. Treatment with antibiotics or for a culture confirmed infection typically leads to a resolution of aneurysm. Similarly, in a patient with secondary aneurysm plus polyuria and polydipsia and a low urine specific gravity on urine analysis, polyuria, polydipsia, polyphagia for like diabetes, and low urine specific gravity may be diabetes insipidus. Okay, lowest on urine analysis may be indicated of diabetes insipidus, and glycosuria suggest diabetes mellitus. Furthermore, the presence of hematuria or proteinuria may require further workup for CKD, metabolic panel, and renal ultrasound. Okay, voiding diary. Where is the voiding diary? Voiding diary for what? Okay, next, look at the BCD. In an otherwise asymptomatic child with normal blood pressure on examination, as with this patient, reassurance may be provided. If the urine analysis is negative, further evaluation of emotional stressor, parenteral discord should be parenteral discord also be considered. In addition, similar to management of primary aneurysms, behavioral modification, restriction, evening fluid, and avoiding caffeine, and a diary to better understand the patient's voiding pattern may be suggested. Okay,
So either way, even if it's primary or secondary,
renal analysis, yes. Is there any screening for bladder cancer? Okay. Bladder cancer is the second most common urologic cancer after prostate cancer. Prostate, then bladder. In United States, most cases arise in older individuals who have had chronic exposure to carcinogen in tobacco smoke, the workplace, aromatic amines, or drinking water, arsenic from well water. A family history of bladder cancer is first degree relative and is associated with increased risk. However, bladder cancer screening been has not been shown to provide a significant increase in survival. This is likely because current screening tests have either low specificity urinalysis or microscopic hematuria, leading to unnecessary workup of false positive result, or low sensitivity urine cytology, urine tumor marker, leading to missed diagnosis. Okay. Okay. This older male, this older male who underwent inguinal hernia repair now has vague lower abdominal discomfort, and distension in central lower suprapubic abdomen. This presentation is concerning for this presentation is concerning for postoperative urinary retention and should prompt portable bladder ultrasound. Postoperative urinary retention and should prompt portable bladder ultrasound. Urinary retention is a common postoperative complication factor Factors associated with increased risk of postoperative urinary retention include patient's factor including age, male sex, prostatic enlargement, type of surgery, hernia repair, joint arthroplasty, and or anorectal operation, anesthetic factor, prolonged anesthetic duration, excessive fluid administration, and the use of medication opioid anticholinergic that impair bladder emptying. Patients with postoperative urinary retention may have suprapubic discomfort and bladder spasm. However, symptoms are often masked due to residual anesthesia and analgesia. Physical examination often shows suprapubic fullness that is uncomfortable when palpated and or dull when percussed. In addition, hypertension and tachycardia may be present for sympathetic stimulation. The distended bladder is a noxious stimulus. Portable bladder ultrasound bladder scan is the first initial step in diagnosing postoperative urinary retention because it is quick, non-invasive, and it can be performed at the bedside. If postoperative urinary retention is more than 600 ml on ultrasound with the different source listing different cutoffs, so urinary catheterization is typically performed. Okay. Evolution of the hyponatremia. If there is hyponatremia, serum osmolality, if serum osmolality is more than 290 milliosmol per kg, yes, then AM, advanced renal disease and marked hyperglycemia. If no, then urine osmolality should be done. If urine osmolality is less than 100, if urine osmolality is less than 100, yes, it is PM, primary polydipsia, and malnutrition, beer drinker, potomania. If no, if urine osmolality is less than 100, yes, it is either primary polydipsia or malnutrition. If no, then we should do urine sodium. If urine sodium is less than 25 milliosmol, if urine sodium is less than 25 milliequivalent per liter, then it is volume depletion, congestive heart failure, and cirrhosis. If it is no, urine sodium is not less than 25 milliosmol, 25, then it is SIADH, adrenal insufficiency, and hypothyroidism. I don't know actually. You can search. I I I, I don't have idea. Gemini. I don't know why your Google works so lazy. So excessive consumption of the beer can cause hyponatremia. Okay. Okay. I am reading the explanation. This patient has had this patient has had seizures due to hyponatremia. Hyponatremia is often excessive. Hyponatremia is often due to excessive antidiuretic hormone secretion. Hyponatremia is often due to excessive ADH hormone secretion leading to impaired renal excretion. However, hyponatremia can also be due to significantly increased water intake that overwhelms the kidney's ability to excrete water. One approach to evaluate hyponatremia is to measure osmolality. A serum osmolality more than 290 milliosmol per kg suggests either marked hyperglycemia and advanced renal failure as likely cause of the hyponatremia. The next step in evaluating the serum osmolality, if it is less than 290, then you need to measure the urine osmolality. If urine osmolality is less than 100, as seen in this patient, either primary polydipsia or BR potomania. Primary polydipsia is common in children with psychiatric manifestation, schizophrenia, possibly due to central defect, possibly due to central defect in thirst regulation. These patients continue to drink water despite a decreased serum osmolarity that should normally inhibit the thirst reflex. The kidney increases water excretion, which dilutes the urine maximally to an osmolarity less than 100 milliosmol per kg. However, hyponatremia can often develop if the water intake is higher than the kidney's ability to excrete water. Patients with significant hyponatremia can develop confusion, lethargy, psychosis, and seizure.
The safety of which
He has cirrhosis. Oh, yes. Okay, look at the box first. The pathophysiology of hepatorenal syndrome. The pathophysiology of hepatorenal syndrome in advanced renal disease. Sorry, advanced liver disease. What am I seeing? Okay. Portal hypertension causing splanchnic vasodilatation, which will decrease effective arterial blood volume, and decrease effective arterial blood volume will decrease BP, chronically decrease BP, and decrease effective arterial blood volume will decrease renal perfusion, which will increase the RAS activity, and renal vasoconstriction and sodium retention, which will cause ascites, often, and overwhelmed renal vasoconstriction, acute and refractory renal failure, death without death without liver transplant. Okay, hepatorenal syndrome is most common cause of acute kidney injury in patients with advanced liver disease. In cirrhosis, the reduced portal blood flow that accompanies portal hypertension leads to excess local release of vasodilated nitric oxide. The resulting splanchnic vasodilatation contributes to the pooling of blood within the abdomen and decreased systemic vascular resistance. Both of these effects reduce effective arterial blood volume and blood pressure, leading to sympathetic nervous system and RAS. The sympathetic nervous system and RAS are potent mediator of vasoconstriction, though typically insufficient to counteract the intense vasodilatory state of splanchnic circulation. Renal vasoconstriction and sodium retention create volume overload and ascites. Diuretics are initially effective, however, the patient's condition can become diuretic resistance as the hormonal cascade progresses. As the hormonal cascade progresses, sometimes the condition progresses to a phase of overwhelmed renal vasoconstriction, often precipitated by specific insult, infection, GI bleed. Rapid development of oliguric AKI ensues, with urine studies demonstrating a prerenal etiology, benign urine sediment, and low urine sodium. Because of the overwhelmed hormonal cascade, AKI is refractory to volume expansion albumin, as in this case, and liver transplant to undo the cascade is the definitive treatment. Okay. Yes. Intravascular volume depletion. Intravascular volume depletion is the common cause of prerenal AKI that can be precipitated by excess use of diuretics or laxatives. However, this patient has had no improvement in his AKI despite receiving IV volume expansion with normal saline albumin making the volume depletion unlikely. Okay. Sorry, nephritic.
It will be nephritic.
Yes, there is red blood cell, RBC cluster, and C3 is low. C3 is low in PSGN also. IgA comes with like respiratory tract infection, and in IgA has a normal C3 C4. Okay, nephritic syndrome. Glomerulonephritis are characterized by glomerular inflammation, which results in acute onset hematuria, red blood cell counts on urine analysis. Additional clinical feature may include the explanation. You want me to read the box first? Okay. Additional clinical feature may include mild or moderate proteinuria 1 plus protein on urine analysis, acute kidney injury, edema, periorbital swelling, and hypertension. In children, the most common cause of nephritic syndrome is acute post-streptococcal glomerulonephritis, which often develops several weeks after group A streptococcus infection, pharyngitis sympatico, uh, acute post-streptococcal glomerulonephritis when antigens on nephrogenic strain on group A streptococcus from IgG or IgM immune complex, they are that are then deposited between the glomerular basement membrane and the mesenchyme subepithelial. The IgG and IgM immune complex have high complement fixing activity leading to complement system activation and the accumulation of complement component C3 in the glomerular deposits, causing low serum level C3 and CH50. These results in a leukocyte inflammation that thickens the glomerular basement membrane, leading to decreased glomerular filtration, elevated serum creatinine, and fluid retention, edema, and disrupts the epithelial podocyte, causing increased glomerular damage and permeability. Nephritic syndrome treatment of acute post-streptococcal glomerulonephritis is supportive diuresis, blood pressure control, because symptoms typically resolve within weeks. However, lab abnormalities may take months to normalize. Okay, yes. IgA nephropathy. In IgA nephropathy, there are several days after upper respiratory tract infection or spontaneous, most common in young children. Pathogenesis is IgA-based immune complex deposition in mesenchyme. IgA-based immune complex deposition in the mesenchyme. Clinical feature there is gross hematuria, often recurrent, flank pain, low-grade fever, hypertension, may be asymptomatic. Lab is urine analysis plus protein, RBC Cas, and serum normal C3, C4, and increased creatinine. And in acute post-streptococcal glomerulonephritis, there is weeks after group A streptococcus infection, pharyngitis sympatico, most common in school-aged children. Pathogenesis immune complex deposition along glomerular basement membrane subepithelial. Clinical feature gross hematuria, edema, hypertension may be asymptomatic. Lab is urinalysis plus protein, RBC gas, serum, decreased C3 and CH50 or normal C4 and increased creatinine. Okay. Okay. As just hyponatremia. As it can cause hyponatremia. Okay. This patient, this patient developed, this patient developed a seizure while being evaluated for a new onset encephalopathy, lethargy, confusion. A most common cause of seizure is increased in the neuronal toxicity caused by electrolyte imbalance. The patient has recently, 3 weeks ago, given hydrochlorothiazide diuretics, which can cause severe hyponatremia, especially in elderly patients with a low BMI. Elderly patient low BMI can cause severe hyponatremia. Affected patients likely has combination of increased water intake, natural tendency to polydipsia, and an increased water retention, impaired water excretion leading to hyponatremia. Some patients have thiazide-induced mild volume depletion. Thiazide-induced mild volume depletion that causes antidiuretic hormone mediated water retention. However, most are euvolemic, moist mucous membrane likely signifying ADH dependent mechanism. ADH dependent mechanism. These mechanisms may reflect either direct hazard effect or patient's factor age reduced ability to dilute urine, genetic predisposition to water retention, and decreased GFR. Clinical findings are subtle confusion, but seizures can occur with severe electrolyte abnormalities. Treatment of thiazide-induced hyponatremia include permanent thiazide discontinuation and IV fluid administration. Hypertonic saline is typically used in severe cases, seizure. In addition to hyponatremia, thiazides may cause hypercalcemia. Thiazide may cause hypercalcemia that is usually not sufficient to cause encephalopathy. In addition, hypercalcemia is not associated with seizures because of decreased neuronal toxicity. Yes, hyperglycemia, lipidemia, uricemia, calcemia, and hypokalemia and metabolic alkalosis, both thiazide and for loops. And now it can cause hyponatremia also. Yes, loop. We know that loop loses calcium. So in loop diuretics there is hypocalcemia and hypokalemia and metabolic alkalosis both for thiazide and loop and metabolic alkalosis. Uric acid is normal, isn't it? Okay, low. Normal. Right, right. Urine osmolality is urine osmolality is high, isn't it? Normal. Normal. What is normal urine osmolality? Okay. Yes. That one. Maybe. No, no. Urine osmolality. Maybe you are right. I don't know. Is it that chart we have already read? The hyponatremia chart. If urine osmolarity, yes, if urine osmolarity, If urine osmolarity is low, then it is primary polydipsia or BR potomania. And if urine osmolarity is high, then we will check the urine sodium. If urine sodium is more than 25, then the three cause VCC like volume depletion, cirrhosis, and cardiac failure. If volume depletion, sorry, if volume depletion is high, sorry, if urine sodium is high, then these three cause. If urine sodium is low, then SIADH. Rest of the two I forgot, isn't it? Or I am wrong? Maybe no. You choose your answer. Maybe I am wrong, but we are on the track. Okay, you go your way. That yes, certainly necessary. Yes, it can cause SIADH. SSRI can cause SIADH. Yes. Urine sodium is high. Urine sodium, um, like more than 25, there are three causes like SIADH and SIADH or adrenal insufficiency or hypothyroidism. Okay. Yes, that's true. Okay. Okay, first look at the box. In SIADH, there is CNS disturbance, stroke, hemorrhage, trauma, medication, carbamazepine, SSRI, carbamazepine, SSRI, NSAIDs, lungs, lung disease like pneumonia, and ectopic ADH secretion, small cell lung cancer, pain, and or nausea. Clinical feature mild or moderate hyponatremia, mild or moderate hyponatremia, nausea, forgetfulness, severe hyponatremia, there is seizures, coma, euvolemia, moist, uh, mucous membrane, no edema, no GVT. In SIADH, there is hyponatremia, serum osmolality is low, less than 275, urine osmolality is higher, more than 100 milliosmol per kg, urine sodium is more than 40. Management is fluid restriction with or without salt tablet, hypertonic saline for hyponatremia. So this patient has symptomatic hypotonic this patient has symptomatic hypotonic serum osmolarity less than 275, hyponatremia due to SIADH. Normally, the kidneys are able to excrete a free water at sufficient rate to prevent blood hypotonicity. However, in SIADH, inappropriately high level of ADH hormone prevent the kidneys from excreting dilute urine, leading to urine osmolarity more than 100 milliosmol per kg, and hypotonicity and hyponatremia develop. Patients with SIADH are typically euvolemic. Therefore, urine sodium concentration is typically elevated more than 40. Unlike in patients with hypovolemia, in addition to SIADH, serum uric acid levels are characteristically low. Serum potassium level is normal and acid base level is normal. SSRI reuptake inhibitors are commonly associated with SIADH, and elderly patients are especially at risk. Elderly patients are especially at risk. Nausea can further exacerbate SIADH. However, SIADH vary and depending on and severity and rate of development of hyponatremia. Patients can be asymptomatic, mildly symptomatic nausea, lethargy, or in severe cases, most patients with profound confusion, seizure, and coma. Okay, yes. Intracranial neoplasm may lead to hyponatremia. Intracranial neoplasm may lead to hyponatremia due to SIADH or cerebral salt wasting caused by increased intracranial pressure. However, the absence of papilloedema and focal neurologic signs, focal weakness in patients makes the intracranial neoplasm less likely. It is urine osmolarity, isn't it? Just It is that chart. Like
Uh-huh.
if there is hyponatremia, what we'll do first? We will do the serum osmolarity.
Okay.
Then the next step is urine osmolarity. Then the next step is urine sodium. So in
They
here,
didn't
yes, they didn't do the serum osmolarity here. That's true, but but yes, that is one point. But the according to the cause, like it looks like urine osmolarity because what can I say? You know, if urine osmolarity is like more than okay, they haven't give the urine osmolarity. Kidney is kidney stone is related to SIADH. Mm, not likely, isn't it? They are saying that it is euvolemic hyponatremia. Major cause is SIADH and primary polydipsia. So what's its cause? Main. Okay, I'm reading the explanation. Then we will find the clue. Okay, this patient. So this patient with an unremarkable CT scan. This patient with an unremarkable CT scan of the head experienced a seizure, likely due to severe hyponatremia. Although serum osmolarity is often obtained first in patients with hyponatremia, it is typically most useful in patients in it is typically most useful if a patient has predisposing factor for hypertonicity, such as significant hyperglycemia causing translocational hyponatremia or isotonicity, such as lipidemic serum, sometimes causing lab artifact pseudohyponatremia. Otherwise, in most patients, hyponatremia is likely hypotonic, less than 270. I'm not getting it. One word. Sorry. And serum osmolarity can be calculated with 2 into sodium, isn't it? Like if you want to calculate the serum osmolarity, uh, 2 into sodium, like 2 times of sodium is serum osmolarity, approximate value of the serum osmolarity. Do you know that? So they are talking like uh, so we can calculate serum osmolarity, and in here serum osmolarity is nearly 236, like 118 into 2, like 236, which is less than 275. So it is hypotonic hyponatremia. Got my point? So want like if you want to classify a case of hyponatremia, then you need the serum osmolarity, and serum osmolarity, it may be hypotonic, it may be isotonic, it may be hypertonic. Are you getting my point? So hypotonic is less than 275, that they are talking. Otherwise, in most patient, hyponatremia is likely hypotonic. So so although I am reading again, although serum osmolarity, look here, I'm although serum osmolarity is often obtained first In patients with hyponatremia, it is typically most useful in patients predisposing risk factor for hypertonicity, such as hyperglycemia causing translocational hyponatremia or isotonicity. Got it? The last 2 points, isotonic and hypertonic, they are talking about these two. Like hypertonic is translocational hyponatremia due to hyperglycemia. In the box, and yes, no, they calculate the serum osmolarity too. So, so again, you tell your point. I do not get it. Yes, yes, yes. Okay, I got it. The most patient has hyponatric hyponatremia. Like most of the cause is hyponatric hyponatremia, and if it is isotonic or hypertonic, then we need the osmolarity. Yes, then we can start with the urine. Yes. Okay. So hypotonic hyponatremia. So in hypotonic hyponatremia can be further subclassified based on volume status. Can be further subclassified based on volume status, hypovolemic or euvolemic or hypervolemic. These important presentation is not consistent with volume depletion or overload, or so she likely has euvolemic hyponatremia. So she likely has euvolemic hyponatremia. Major causes include SIADH and primary polydipsia. Euvolemic hyponatremia major cause is primary polydipsia and SIADH. Okay. Now SIADH, whereas generalized anxiety disorder and nephrolithiasis predisposed to primary polydipsia, and drinking an excessive amount of water to avoid another stone. Urine osmolarity measurement can differentiate between primary polydipsia and SIADH. Low urine osmolarity, less than 100 milliosmol per kg, reflects massive water ingestion leading to dilute urine. This finding is consistent with primary polydipsia. High urine osmolarity more than 100 milliosmol per kg reflects water being pulled out of the urine in case of ADH, resulting in concentrated urine. These findings also seen in the setting of excess ADH, SIADH, polyuria is another factor. Polyuria is another factor that can lead to distinguish between these disorder and present in primary polydipsia, absent in SIADH. But confirming polyuria in a timely manner can be difficult, limited ability to establish a history in this patient, making urine osmolarity measurement particularly helpful. Yes, yes. Initially, like what they are doing, they are excluding the hypertonic and isotonic. How? Like if it is hypertonic, the serum sodium would be like 145. If serum sodium is 145, then the serum osmolarity is more like it is, what can I say, 145 into 2, like 290 or more than 290. So it may be hypertonic, but if we calculate the serum osmolarity in here, it is actually hypotonic. So the isotonic one and the hypertonic one easily exclude. Yes, A- and we get the serum osmolarity. Yes, and like then then if we go through the cost too, like hypertonic is a translocational hyponatremia, like hyperglycemia. There is no such feature in here. And the isotonic, like there is pseudo hyponatremia. Uh, there is no such feature in here. So these two actually exclude out. Then we need the hypotonic part. For hypotonic part, we need either urine sodium or urine osmolarity. That that's why we need the volume. Now, is it euvolemic? Is it hypervolemic or is it hypovolemic? So that is another thing, like how we can calculate the volume. Mm, we need the volume. You don't know that is it hypovolemic or euvolemic. Okay, we found that it is like serum osmolarity is low. We got up to this, isn't it? So it is hypotonic. Our serum osmolarity is like 236. So it is hypotonic. Now we need uh, the ECV, like extracellular volume. So how we can calculate this one, the ECV? You are getting my point. Why we are jumping on say urine osmolarity? Why we are not jumping on urine sodium? That's my another question. Urine sodium. Yes. That's the sequence. Yes, I got it. That's the actual sequence. If we follow the sequence, but we found that it is hypotonic hyponatremia, and why the how we can calculate the volume, like uh, yes, the volume one. So is there any way of like They in this system, look, the hypotonic hyponatremia can further subclassified on the volume status. Got it? These patients, the second para, this hypotonic hyponatremia, the further classified on the volume status, hypovolemic, euvolemic, and hypervolemic. This patient's presentation is not consistent with volume depletion or volume overload. So she likely has euvolemic. So that is the thing. If it is volume depletion, like volume loss, like vomiting diarrhea, or what they have said, volume depletion or volume mm, overload. Yes, it is not volume overload. So how we can know it is volume overload? If there is volume overload, there may be features of like lungs problem, like crepitation, maybe. So that's the way of thinking. Yes, there is no extremity edema. Okay, there are plenty of things we should look at. So now it makes sense. You want to take a break? You have you done your breakfast? Okay, you do your breakfast because Renal is killing us. Okay, bye bye.